cloud. And Dr. Chang, it's all yours.
Okay, great. Let's go to presentation. Okay. So as Mark said, we've been doing this for about 12 years, and thank you everybody for carving out some time on a Thursday evening. And I know for those of you on the East Coast, this is getting late in the evening there. But of the various topics we've talked about over the years, we haven't really specifically had a full talk on this topic. And I came to the idea to do this topic actually from one of the other support groups that I run. There's another type of benign tumor called a meningioma, and I gave a presentation on when you should just watch a meningioma, or when should a meningioma not be treated, and that actually got a lot more views than all the presentations on treatment by, I don't know, factor of 20 to 1. So I think there's a lot of people out there that would have kind of the same thoughts and questions about acoustic neuromas. So hence the topic for tonight. So the first thing I want to do is just define what watchful waiting or observation is, and it's basically involved just monitoring both MRI scans and symptoms. So you have a diagnosis of an acoustic neuroma. We're going to observe. So we're going to watch both the symptoms and the scans. And you need to do both, because sometimes a tumor could change without any new symptoms. And sometimes the symptoms can change in the absence of any tumor progression. So you want to watch both. This is typically done with MRI scans performed at selected intervals, and the exact timing of the intervals is a little bit up in the air. Historically, you want to monitor frequently enough that you don't miss something. But when you do monitor with scans, especially if you get the contrast with the MRI scan, there's been kind of this small concern about how often is it okay to get contrast over your lifetime. So in some instances, I've switched to non-contrast MRI scans if I can still see the tumor. And then we also want to watch, your hearing as well. So this is typically done with audiograms for patients that have hearing. And so in terms of why you would consider observation, first, a lot of times acoustic neuromas are discovered when the tumor is small. And so we'll see in some of my subsequent cases that I'll show you, if the tumor is small, depending upon the age and the other medical conditions of the patient, this might not be the biggest priority. I saw a couple of acoustic neuroma patients today in clinic for the first time, and in both cases, they had their tumors discovered as incidental findings. So they're not always symptomatic when they're discovered. Another situation which you might want to observe is depending upon how old the patient is. And we do know that acoustic neuromas grow very slow. And so if a patient is elderly to the point that we based on expected lifespan, we think their lifespan may not be in the order of decades, it might be reasonable just to watch. This may not be their biggest problem. And then the last situation is acoustic neuromas that are discovered in patients with more pressing medical conditions, and I'll give some examples of those. So the goals tonight, we're going to discuss which situations it's reasonable to observe acoustic neuromas. We're going to discuss the advantages of just watching, and then I'm going to have a number of slides on the potential disadvantages, because watching in observation mode is not the same as zero risk, and that's a concept that sometimes I think newly diagnosed patients don't understand. They think, well, if I choose radiation or surgery, that involves risk. If I watch it, there's no risk, and that's not the case. We'll talk about that today. So I'm going to walk through just a couple of cases where I think it's reasonable to say we can observe this patient. So this is a 65-year-old male. He's got right-sided tinnitus, the ringing in the ear. He's got a little bit of high frequency hearing loss. in both ears. So the side of the tinnitus is not any worse than the left side. He's got a normal exam. He's got and he gets his very first MRI scan, and you can see in this MRI scan there's a very small acoustic neuroma right there, and we would measure this at about 8 millimeters. So, because this is an MRI scan that the first time he's ever had a scan, we don't really know how long this has been there. We can extrapolate backwards and say, well, if they grow on average 2 millimeters a year, and this is 8 millimeters, then 8 divided by 2 equals 4. So maybe this has been there for 4 years, but maybe it's been there a lot longer. We don't know. I always like to tell patients that each MRI scan is a data point on a graph. And if you have a graph with just one MRI scan or one data point, you have no idea if there's a trend line or really what's going on. So in this situation with a small tumor, minimal symptoms, it might make sense just to observe and get an MRI scan, let's say in 6 months, to see if there's a change. The next MRI scan will be another data point on the graph for the patient. I think observation is not something that is totally set in stone. You can observe for a period of time and then elect to treat. So just because you pick observation doesn't lock you into that situation. But so this is kind of the most common situation in which observation would be reasonable, which is a small tumor, newly diagnosed in a patient without a lot of symptoms. So here's another patient. This is a younger patient, 33-year-old female. She comes in with a 2-week history of headaches. She thinks it might be related to her menstrual period. She's got a total normal neurologic exam, no tinnitus, no hearing loss, no other neurologic deficits. And this is her MRI scan. And if you thought the last patient had a tiny tumor, this one has even a smaller tumor, measures probably about 3 millimeters right here on the contrast scan, which is this lower sequence here. If you look at figure A, this is a non-contrast MRI scan, and you're really hard pressed to see if there's a problem going on in the left ear. This is what we call the coronal view, or the vertical slice. When we look at the horizontal slice, you sort of can make out this little gray ball here. This is, again, a non-contrast MRI scan. And then after the delivery of contrast, we can see the little white spot there. So this patient, it certainly has symptoms. They're headaches, but again, they're not likely to be related to the tumor. She even thinks they're related to her menstrual period. So this is a completely incidental finding, and you can see how small this tumor is. So it may make sense to kind of observe this, because if the patient has no symptoms related to the tumor and the tumor is small, you're really, the tumor really hasn't declared itself as any major threat. One could argue she's young, and so at some point this might become a problem, but it certainly does make sense to say, given that this tumor is tiny, we can just watch it. If you look at between C, which is the contrast MRI scan, and B, which is the non-contrast MRI scan, you can see that once you know where the tumor is, you can actually see it on the non-contrast MRI scan, and you can measure the size on the non-contrast MRI scan. So it does potentially allow this patient to switch to non-contrast MRI scans as they observe their acoustic neuroma. Okay, case number 3, 90-year-old neurosurgeon. I always pick neurosurgeons as case examples to make fun of. So we got a 90-year-old neurosurgeon. He has hearing loss on the left side, and he's got tinnitus on the left side, so we're guessing he's probably got a left acoustic neuroma. Everything else seems to be pretty good. His balance is good. His facial function is normal. And so he's got this tumor. So compared to the first 2 cases, we can clearly see that this is a larger tumor. There's a little bit of compression on the brainstem there. This would be measuring a little bit more than, let's say, 2.5 centimeters or 25 millimeters. But, other than the small amount of symptoms that he's having, he's actually not really impaired by this. He's got no balance problems or anything like that. So you could look at this and say, well, geez, it's big. We should consider treating it. So, but you need to kind of consider, in his situation, his age. He's 90. So if you were talking about surgery, a tumor like this size would probably be about an 8 to 10 hour surgery. So for a 90-year-old to have to do an 8 to 10 hour surgery for something that's not causing any acute problems for him, might be questionable, especially if he has a complication from the surgery related to his heart or lungs. You could say, well, what about radiosurgery? This is still within the size criteria for radiosurgery, in my opinion. So you could do radiosurgery on this tumor, but we know that radiosurgery takes about 3 years to kill the tumor. So in someone who's 90, if we treated him right away, maybe we could say we killed the tumor by the time he's 93. But again, is this going to be the main issue for him in his remaining lifetime? And given that he's not symptomatic from this or minimally symptomatic, it may make sense to just consider observation. Okay, so here's another patient, and this is a little bit different than the first 3 cases I showed you. Those first 3 cases are all patients that have unilateral, or what we call solitary, acoustic neuromas. Are on one side. So those are not no genetic predisposition. This is a patient with neurofibromatosis type 2, and in NF2 patients, they have a genetic disorder that predisposes them to 2 acoustic neuromas, one on each side. And so this is almost like a mirror image. Here's the one on the right, and here's the one on the left. She's 26-year-old, and she's got no symptoms. The only reason why she got an MRI scan is that this NF2 gene runs in her family, and other family members had acoustic neuromas, but she's clearly not symptomatic, no tinnitus, no hearing loss. And in this situation, here's the problem. We suspect that based on her age, young age, she's got many decades to go, that these will likely grow, but it's not clear which one would be the first to cause problems for her. For example, hearing loss. How can we tell? They're about the same size. She has normal hearing on both sides. So which one is going to be the problem? And the reason why this creates a little bit of a dilemma for treatment is under the following scenario. Let's say we say, well, let's treat the tumors when they're small, either with surgery or radiation. And we're going to treat this right tumor. So let's just start with one side. We're going to pick the right side and treat that. Now, let's say we could predict the future, and 5 years from now, it'd be the left tumor that causes complete hearing loss on that side. Okay, that's we could look into the future, and 5 years there, that's the problem. But we're at the present, and we don't know that the left tumor is going to be the problem in the future and cause hearing loss. And so we're at the present, we treat the right-sided tumor. And let's say, as a result of the treatment, the patient does develop some hearing loss, or let's say she loses complete hearing on that side. Now, fast forward 5 years later, the left-sided tumor causes hearing loss on that side, and now she can't hear on either side. So in this situation, it may be wiser to follow the patient with observation and see which tumor declares itself as the greater problem. So which tumor is either growing the fastest or which tumor actually impacts hearing. So let's say these tumors grow equally, and 5 years from now they're twice as big, but the left tumor has caused complete hearing loss on the left side, and the right tumor the patient has normal hearing. At that point, it would make sense, if you're going to treat a tumor, to treat the one on the left side, because she's already had hearing loss on that side. And once you have hearing loss, you're not going to lose any further hearing if you have complete hearing loss. So that way, by observation, you could plan accordingly and keep her hearing at least in one ear as long as possible, rather than picking one side, treating it, and only to find out that was the other side that was the bigger issue. Here's another case. So this is a patient that had a pretty large acoustic neuroma, and they wanted surgery. And at the time of surgery, the tumor was really socked in and stuck to the facial nerve. So a near complete resection was done. We would call this, let's say, a 90% resection. There's some tumor that's attached to the facial nerve, cannot be removed at that point. So this is a situation where, the patient's better, the brainstem's decompressed, they've recovered well from the surgery. but there's a small residual there. How are you going to manage it? Are you going to just observe it, or are you going to treat it up front with radiation, or what's the strategy here? And so it turns out that if there's a small residual tumor left, more often than not, they may not grow because you've disrupted the blood supply to the tumor. You've kind of devascularized it enough that it won't be very viable. So in these situations, it may make sense, at least in the short run, to observe this residual tumor. And if over time it never grows, then you can continue to monitor it. If it does start to show some growth, you always have the option of doing stereotactic radiosurgery. But I think the philosophy of many neurosurgeons has changed over the last 2 decades with these subtotal resections. If you're getting most of the tumor out, the residual more often than not doesn't grow. So 20 years ago, we would say, okay, now you need radiosurgery for this. But now at the present, we're more likely to observe and see if the tumor declares itself before committing toward radiation treatment. And then the last example I want to show before we go into some of the discussion is this phenomenon of transient enlargement. So this patient is one of our early patients that was treated with CyberKnife, and they had a small tumor on the right side. They wanted treatment, and we know during the dying process there can be some inflammation that can cause the tumor to swell, and so the tumor did get larger here. And this is a situation where some patients might panic and say, my tumor's getting bigger, the treatment's not working. And we would say, we understand inflammation can cause this, so let's just observe it. And you can see over the next couple of years, the tumor shrunk back down. So understanding the mechanism by which the tumor can become inflamed as it dies helps to reassure patients that what we're seeing with this temporary enlargement is just part of the actual treatment process. Oh, last case. We have a 72-year-old male. He's got a medium-sized acoustic neuroma, about 2 centimeters, but completely not symptomatic from this. And then let's suppose he has any one of another set of serious problems, either lung cancer or cirrhosis and liver failure or end-stage heart disease. Clearly in this case, the acoustic neuroma is not the priority in terms of this patient's health. And so attempting to try to treat this acoustic neuroma when he's got larger health issues on his plate may not be reasonable. In this case, observation makes a lot of sense. It allows the patient to focus on his other acute medical issues. So what are the advantages of observation? We know that some acoustic neuromas never grow over the lifetime of the patient. It seems that the longer the tumor has been stable, perhaps the less likely it is to grow. So a tumor has really done nothing for 10 years. Is probably less likely to grow than a tumor that has done nothing for just 2 years. There does seem to be some data that as we get older, there is potentially a slower growth. And also coupled with that is that the time period from diagnosis to, or at least the duration of survival of the patient, just their general lifespan is less. And so there's less time for any kind of tumor to grow. The other advantage of observation is the patient does not need to make a decision regarding treatment at the present time. Certainly with an early diagnosis acoustic neuroma, when you're sorting through the different options for treatment, it can be overwhelming with a lot of data and information. And observation, getting a scan in another 6 months, gives you at least that window of time to collect your thoughts and seek a variety of opinions and be a little bit more thoughtful in terms of how you want to manage this. So if the tumor is watched and does not grow, that would be the ideal situation. I always tell patients, look, if we had a crystal ball and could predict that the tumor would never grow in your remaining lifetime, the correct option is no treatment. But the problem is there's no way to really predict this. And if we observe and the tumor grows, there's no way to go back in time to when the tumor was smaller. So in terms of disadvantages of observation, I mentioned at the beginning of this talk that progression of symptoms do not necessarily match growth of the tumor. So you can have absolutely no change in the size of the tumor on MRI scans, but have significant worsening in symptoms. And this could be troublesome to patients because they feel, well, if my symptoms are getting worse, that must mean the tumor's growing. And why does MRI scan not show that that's the case? It's also possible to have the reverse happen, where the tumor grows rapidly and there's no change in symptoms. So one of the disadvantages of observation is that for treatment of these tumors, the risk is proportionate to size, and I'll talk about that in the next couple of slides. And so by observing and letting the tumor get larger, it actually makes treatment more difficult. Another disadvantage of observation is, when you know the tumor is not treated, you're often more sensitive to any symptom that might be related to the tumor. So if you were to develop headache or have some ear fullness or have some balance issues, you might be overly concerned that this represents some tumor progression, and this anxiety can often create a lot of low-level stress for patients as they're trying to understand if the tumor is resulting in the symptoms or not. There's some uncertainty in terms of whether or not treating the tumor will make your symptoms better. So if some patients come in and say, well, I have headaches and I think they might be related to the tumor, but I'm not completely sure. By observing the tumor, it's very difficult to say that whether the headaches are related to the tumor or not, because we haven't eliminated the tumor from the equation. So in some situations, if you're sifting through trying to figure out, are the headaches related to or not related to the tumor, observing the patient doesn't eliminate the tumor as a possible source of the headache and doesn't help you solve that problem. And then the other disadvantage of observation is, again, the timing of MRI scans. I mentioned this previously in the talk. How frequently do you get MRI scans? Should you get the contrast dye with the MRI scans? MRIs are not radiation, so there's no issue there, but they do come with a cost. And there's some concern about the repeated risk of getting contrast dye just to kind of look and see what's going on. So I mentioned that tumor size is proportional to success of treatment. And as tumor size goes up, the complication rate goes up as well. And here's the reason for this. If we assume the tumor is kind of a round ball, we often look at the MRI reports and we see linear measurements. Your tumor is 9 by 15 millimeters or something like that. We're not, the reports are not giving you the volume of the tumor. So the tumor is a sphere roughly, and we can calculate the volume, the three-dimensional volume of the tumor through some geometric formulas. But really the bottom line is you can see that the volume of the sphere goes up by the cube root of the radius. Okay, so as the radius or the diameter of the tumor doubles, the volume is going to go up by a lot more. And this is the graph that we see here. So if you have a tumor that's 1 centimeter in diameter, you can see its rough geometric volume if we use this formula. This is approximate. If it just grows to 1.3 centimeters in diameter, you see the volume is already doubled. And if the 1 centimeter tumor goes to 2 centimeters, the volume goes up by a factor of 8 because you're cubing the radius. If it goes from 1 to 3, the volume goes up by a factor of 27. So a 3 centimeter tumor is not 3 times bigger than a 1 centimeter tumor. It's actually 27 times bigger than a 1 centimeter tumor. And so by watching the tumor, you're running the risk that small changes in diameter will translate to much bigger changes in volume, and the tumor volume will sneak up on you as it enlarges, because we're looking at diameters and we are lulled into some complacency that, oh, my diameter only changed by 3 millimeters from 1 centimeter to 1.3 centimeters. It's only changed by 3 millimeters. That's tiny, but then the volume doubled. And we know that as the volume increases, the risk of treatment increases. And also, as the volume increases, the likelihood of having a successful outcome decreases. So you have to just factor this into the equation when you're undergoing observation. You may be leading yourself into a situation where you're older and now having a much larger tumor, and therefore the risks of treatment are more significant. So here's what I was alluding to before, that as a tumor grows, let's talk about surgery first. So as the acoustic neuroma tumor gets larger, the surgical risk increases, and that includes risk of hearing loss. So the bigger the tumor, the greater chance of hearing loss with surgery. The larger the tumor, the greater the chance of facial nerve injury with surgery. Larger tumors often require longer number of hours in the operating room. And also, not only while we were waiting and observing did the tumor get bigger, but the age of the patient and their general health, the age likely went up and their general health might have deteriorated. So now you got a larger tumor in an older patient that's not quite as healthy. In terms of radiation treatments or radiosurgery, we have to radiate volume, not diameter. And so as the tumor volume increases, the amount of tissue you have to radiate goes up. And what we do know is that smaller tumors do best with radiation. And you can see some numbers here. For a 1 centimeter diameter tumor, you're going to have tumor control rates about 97%. For 2 centimeters, 94 to 95%. And at 3 centimeters, it's 90%. Okay. So, at 1 centimeter, you might have 1 in 40 to 1 in 50 tumors grow. At 3 centimeters, 1 in 10 are going to grow despite the radiation. So by observing, letting the tumor grow, you're actually decreasing the ability of the radiation to do the best job. We also know that in terms of the symptoms that patients often comment on, which is hearing preservation, the best shot we have for hearing preservation with radiation is when the tumor is as small as possible. As tumors get larger, number one, patients are more likely to start with worse hearing in the first place. But secondly, just in the larger tumors, hearing preservation rates are lower than those with smaller tumors. And finally, in terms of the radiosurgery, there is some data that's now out there that shows that the ability to preserve a patient's hearing is related to the time from initial diagnosis to the radiation treatment. So the best chance you have of hearing preservation is having radiation within 2 years of diagnosis. So it doesn't have to be within a few weeks or a month, but just within 2 years of diagnosis. If you wait longer than 2 years from diagnosis, then the chance of hearing preservation is shown to be lower than those are treated earlier. So that's another disadvantage of observation, is the further out you go, once you do need treatment, your hearing preservation rates are possibly lower. This is a Kaplan-Meier curve, which just shows the tumor control rates based upon size of the tumor. And so in the blue line is those tumors that were smaller, and the red line is those tumors that were bigger. And you can see at the bottom along the x-axis is the time in years. And so if we look at the blue line at 10 years, we still had about 95% of acoustic neuromas were dead, the small ones. But of the bigger ones, at 10 years, we're 89%. So, you'd rather have 98% or 89%. This is the difference between treating a large or small tumor with radiosurgery. Couple of last comments about observation. When your tumor is small, you have pretty much all the options available to you. You have the radiation and the surgery. If you observe the tumor and the tumor gets too large, you may lose radiation as an option. Radiation does have some size restrictions, and if your acoustic neuroma becomes too large, that may be taken off the table. And then the other comment I want to make is that generally the condition of the patient right before whatever treatment they choose is the best predictor of outcome, meaning that if a patient feels well, has minimal symptoms, that is the best predictor that they should have a great outcome. So if you have an acoustic neuroma and you feel great and you're in the observation mode, and subsequently you develop a lot of balance issues and tinnitus and facial twitching, we cannot necessarily reverse those symptoms. That becomes your new baseline. And the treatments, if you rush in for treatment at that point, the treatments are designed to just prevent you from getting worse. We can't necessarily reverse any progressive symptoms that you have. Okay, so to summarize, observation certainly can be a reasonable choice in patients. I showed you 7 different examples where you can make a very logical, coherent argument to observe. It may not be the best long-term option, particularly in younger patients or in patients with larger tumors. But as I said, just when you choose observation, that doesn't commit you to observation forever. You can choose observation and see what the next scan looks like, and then repeat the kind of logic process in terms of treatment. But if you do observe your acoustic neuroma, any worsening in symptoms you have over time may not necessarily be reversed. It's also important to keep in mind that, small changes in the size of the tumor from a diameter standpoint could translate into large changes in the actual volume. And volume is what we have to remove with surgery, and volume is what we have to treat with radiation. So, and then finally, if you observe and the tumor grows and becomes too large, you may lose some treatment options. So if the tumor gets too large, the radiation option, which is non-invasive, may be taken off of the table. And so you may end up in their circumstances with only one viable option left in terms of surgery. And if that's something you were attempting to avoid, then observation might have just created a situation where you ended up with not the treatment of choice that you preferred. So if you choose to watch your acoustic neuroma, it's important that you have a dialogue with your neurosurgeon as to the advantages and disadvantages of the observation. It's also important to make sure you stay on a reasonable regimen in terms of monitoring. Monitoring needs to be done both in terms of clinical symptoms and in terms of obtaining MRI scans. So I think I'm going to stop there and see if there's any questions that people may have at this point in terms of what I've presented. I'm happy to answer any questions related to my talk. I'm happy to also answer other general questions about acoustic neuromas that maybe were on a little bit different topic than what was presented tonight.
Okay. Dr. Chang, as always, thank you. I think you're absolutely right. This is all the topics we've done over the years. I don't think we've always come across this as an option in some of the other talks that you've done, but never focused on it, I think, is with as many variables to the decision process as you've pointed out tonight. So I think that's been very interesting. What's easier? If we got 13 people, do you want people just to raise their hand and I'll recognize them, or do you want to put questions in the chat? What works best?
Either way, I'm happy to just, if you want to type them in the chat, I'll just read them off and just go down the list.
Okay.
That might be easiest. So the first question in the chat box is, should you go through treatment if your acoustic neuroma does not grow? So this is a great question, and the problem is you never know the true answer to this question. Let's say Mark came in with an acoustic neuroma, and over his lifetime it would have never grown, but we go ahead and treat him with radiosurgery, and now 20 years later, everybody is happy that the treatment worked. The reality of it is that if it wasn't going to grow in the first place, then the treatment really didn't do anything, but we would never know. So Mark's happy that his tumor's not growing because the treatment worked, and I'm happy that the treatment seemed to work, but we don't know for sure. We don't have two Marks where we could treat one and observe one and have a control Mark where we know what's going on. So you don't really know the answer to this question in hindsight. And if you wait and observe and the tumor grows, you cannot so-called put the horse back in the barn at that point. So medicine's a very inaccurate science. You have to, it's unpredictable, and you have to deal with a little bit of that uncertainty when making decisions. Another question came up: do you have headaches after radiosurgery? That's not a very common symptom, certainly in the long run. In the short run, as the tumor dies from inflammation, you can have some sense of, it's not really headaches, it's more of a sense of head pressure. Generally, they're manageable, and it's very few patients that require any medication to manage the headaches after radiosurgery. Once the tumor is completely dead, there should be no more inflammation. And so if you have headaches after, like if you're 10 years out from radiosurgery for your acoustic neuroma and you're having headaches, it's probably related to something else. And, you would have to have a standard headache workup. Somebody asked for frequency or follow-up of MRI scans, contrast versus no contrast. This depends upon a whole bunch of factors, whether the tumor's been treated or not treated, how large the tumor is, whether it's changed over, at least the MRIs that we have to date. It also factors into how old the patient is, how much of their quality of life is being impacted. So there's not a one formula, one size fits all for that. In terms of contrast versus no contrast, I'll give you kind of my general philosophy on this. And that is that as the first MRI scan should be with contrast, because we want to make sure that, you don't have a tiny acoustic neuroma that we might otherwise miss. We want to make sure that you don't have some other issue going on ahead unrelated to the acoustic neuroma. But once we have a diagnosis of acoustic neuroma and we can see that, we can see it on the MRI scan, when you get a contrast MRI, they actually also do non-contrast sequences. So I always look at the non-contrast sequences. And if I can say to myself, yep, I can see the acoustic neuroma on the non-contrast sequence, it doesn't quite look as obvious as the contrast sequence, but I can still see it and I can measure it, then I'm happy to switch the patient over to non-contrast MRI scans. And I tell the patient we can keep doing non-contrast MRI scans up until the point, if the tumor does look like it's changing and we have to get more information, then maybe we have to get one contrast MRI at that point. But if the tumor doesn't change, we can continue to monitor with non-contrast MRI scans. Okay, so the next question is, I was diagnosed with acoustic neuroma in May of 2021. Okay, is that your question? Okay, is it okay if I read? I'm gonna keep everything private. I'll just read the general stuff. Is that okay? Okay, so I was diagnosed with acoustic neuroma in May 2021. It was 2.5 centimeters, that's centimeters. In November, it was 2.4 centimeters. So it sounds like there's not much change. So 2.5 and 2.4 centimeters, that's a 1 millimeter difference. And that's actually within the statistical measuring error of physicians when they look at MRI scans. I usually say up to 2 millimeters, plus or minus 2 millimeters is the statistical measuring error. So I would consider 2.5 and 2.4 basically the same, unchanged. There's a comment of you're getting a new MRI scan this Friday. Certainly, I think it would have been reasonable to if that first MRI scan was the first time you were diagnosed, to get a follow-up MRI scan. Now you're getting a second MRI scan. The things that go through my mind would be, we factor in your age and your symptoms. 2.5 centimeters is medium, getting closer to the large size. So unlike the really tiny ones that I've shown, you don't have as much luxury of space as some of those really tiny tumors. But each additional MRI scan that you get that shows a tumor is stable gives you a sense of reassurance. So if someone's had 7 MRIs in a row once a year and the acoustic neuroma has been stable that whole time, that gives a lot more reassurance than just having one MRI and not knowing. So I would suggest in this situation, get the MRI scan. If it shows progression, then I think it's declared itself and you might want to consider treatment. If it shows no change, then you're back to where you are right now. Is, do you just continue to observe in hopes that this medium to large acoustic neuroma doesn't grow any further, and it may not, or do you just treat it for peace of mind? There's no right answer here. on that question. It's just going to be, having a frank conversation with your physician to determine, what make sure you and him are on the same page. Next question. I'm followed by Dr. So-and-so at Stanford since 2017. Last year, my tumor was 7 by 4 millimeters, and this year it's 9 by 6 millimeters. What is the size where radiosurgery would not be effective? The patient has balance impairments and hearing loss on the side of the tumor. Okay, so this tumor, this is one where it looks like it only got 2 millimeters bigger, but probably by the volume formulas that we have, this is probably 75% bigger by volume. So it's growing, but it's still relatively small. It's under a centimeter in maximum diameter. So I would still consider this to be a small tumor. So radiosurgery can be effective up until about 30 to 35 millimeters, and this is only 9 millimeters. So this is very small and well within the size criteria for radiosurgery, even if it were to get bigger. But what you need to keep in mind is a couple of things. Number one is I had that slide that showed that as the size gets bigger, you can still do radiosurgery, but the success rate starts dropping. So as the tumor gets bigger, the chance of killing it with radiosurgery starts dropping. And so you can still do the radiosurgery, but maybe instead of 97% success rate, now you're down to 94. And if it keeps growing, maybe now you're down to 92. So you do lose a little ground with what we call the tumor kill rate as the size increases. The other issue is that we know for you say you have some hearing loss on the right side, but it's not clear if it's complete hearing loss or partial hearing loss. But the likelihood of preserving whatever hearing you have on the right side is better for the smaller tumors. So treating a tumor with radiosurgery when it's small gives you a better chance in general of keeping the hearing than waiting for the tumor to get bigger. So next question. Okay, that was the same question. Okay. Please explain more fully about the risk of contrast. Okay. So let's talk about, so MRI scans have been around since the mid 1980s in terms of kind of use in the medical field. And pretty much since the beginning, these scans, we've used contrast to help us identify lesions. So what contrast is it's a compound that's injected into your bloodstream, and the pathology, in this case, the tumor, will take up some of the contrast and make it more visible to doctors to see on your scan. Okay, so with MRI scans, contrast generally consists of what's called gadolinium. Gadolinium is element on the periodic table. So if you remember from your high school chemistry class or your college chemistry class, the periodic table has all the different elements in it, like nitrogen, oxygen, carbon. Gadolinium is one of the elements in the periodic table. It's in the same kind of general area where zinc and copper are in the table. So it's considered a kind of a metal. And the gadolinium is what makes the pathology, in this case, acoustic neuroma, light up. And so the gadolinium was, you get it injected every time you have an MRI scan, and your body flushes it out through the kidneys, which is why one of the reasons why sometimes we actually will do some blood work before we do an MRI scan to make sure your kidney function is good. What is not clear is whether your body can flush out 100% of the gadolinium that gets injected into you. The thought process is that the vast majority of it gets flushed out of your body. But the thought process is that small traces or small pieces of this gadolinium can stick around in the tissue, including the brain. And that if 99.9% of the gadolinium, for example, gets flushed out, and you only have, 1/10 of 1% left in you, that might not be a big deal if you got one scan. But if you have to have a series of scans over your lifetime, and you maybe had 30 MRI scans over your lifetime, what's the effect of that cumulative effect of gadolinium? Generally we try to use some balance here. We're trying to assess tumors, and that's important. If we can assess them without contrast, then certainly that's the way to go. Generally, for most acoustic neuromas, once you've identified them on the first scan with contrast, they are very well and very easy to define on non-contrast MRI scans. This conversation goes a little bit differently when we're dealing with malignant cancers and patients have multiple cancerous tumors in their brain. In those situations, obviously, I think it's much more important to get the pictures with contrast so we can address the cancerous tumors in the brain, rather than to be worried about a contrast issue that is really unclear at this point. I don't want to kind of make this sound more concerning than it really is, because the whole issue of contrast wasn't even really brought up for about 20 years after the start of MRI scans. So it's one of the things that it's the impact is likely so small that it took a long period of time for physicians to even question whether there was an impact at all, and it's not clear right now that there is. But having said that, just like you would not go get X-rays for no reason, because that exposes your body to low, some radiation, you would want to be a little bit judicious about how many times you need to get contrast. So this is just a conversation with your doctor. Just say, hey, I've had a couple of MRIs in a row and we're just watching my tumor. Can you see it on the non-contrast portion of the MRI scan? And if so, can my next scan be non-contrast?